Hello, everyone, and welcome to the HIAC One-on-One Podcast, brought to you by the Health Informatics and Analytics Club at the University of North Florida. I'm Agrani Sinha, your host for today's conversation. In this series, we sit down with thought leaders and professionals who are shaping the future of health informatics. One guest, one story, one deep dive at a time. And today we are truly excited to have someone whose work blends technology, data, and compassion in one of the most meaningful areas of healthcare. Please join me in welcoming Ms. Rachel Smith, Clinical Informatics Manager at Alivia Care. Rachel, thank you so much for being here with us today. It's a pleasure to have you.
Thank you so much. I'm excited to be here with you.
Yeah, so are we. So let's start. Rachel, many imagine informatists surrounded by screens and spreadsheets, but your work touches people's life in real and compassionate ways. Could you take us behind the scenes of a typical day in your role? What moments remind you that technology and humanity can coexist beautifully in healthcare?
Absolutely. So, great question. So, really, my role is around listening and connecting with our clinicians and understanding the barriers they face while documenting and caring for our patients. These could be our physicians, our social worker, our nursing staff, intake staff. It's really our job as clinical informaticists to understand the voice of our customer and be able to remove barriers that they have. So, for example, we have a lot of burnout today in for clinicians because there's so many requirements that organizations put on them to document whatever it is they're trying to document, whether it's for an organizational improvement initiative or government requirement. A lot of technology today or how it's configured doesn't lend itself to help the clinician document in an easy way. So for us, it's really meeting with those clinicians, helping the clinician document, and really understanding their frustrations and trying to find creative ways that allow them to do their jobs, that satisfies them, and really helps them focus on the primary goal of healthcare, which is caring for the people that we support. So, yeah.
That's such a great perspective. And it actually leads perfectly into my next question. Interoperability may sound technical, but in practice, it's what helps patients experience truly connected care. How do standards like FHIR, HL7, or health information exchanges come into play in your daily work? And how does your team make sure technology feels seamless for both clinicians and patients?
So, one of the things with data, especially in clinical informatics, data is so important. And without data standardizations, different systems don't know what each other are saying. So a good example of this, a simple example of this would be when you go to the doctor and they ask you if you're in pain, and they all have a pain scale from 1 to 10. And everybody knows it, everybody uses it. And so we have a foundation of what we're trying to track and measure. So for healthcare systems, standardization is a must. So we know how we're measuring things. We have the same unit of measure, the same goal. You'll see this in lab values when they have ranges. It would be adverse if patients had different lab ranges or organizations have different lab ranges depending on where they go. Or if we're trying to track weight, for example, and we're using, kilos versus pounds or something like that. And so when you're talking about interoperability and connecting data together, it's really important that we're using the same standardization, the same formatting, so that it's seamless for everything to come together because there's so many different systems. And that is kind of one of the reasons why they have the ONC certifications for EMRs and why HIAC has their interoperability standards. And so technology needs to meet certain standards. Now, I will say, caveat to that is that certain organizations or certain lines of business, acuities of organizations will meet different standards. So, for example, ambulatory care, like your primary care providers or your cardiologies, orthopedics, anybody that you go see at the doctor, they all are held to a certain requirement and certain standardizations, again, through that HIAC interoperability. And same thing with hospitals. They are required to maintain a certain standard. But some areas of healthcare, like hospice that I'm in right now, they don't require the same amount of standardization that the other organizations do. And that really hinders us from being able to share data with each other so that we can take care of the patient and provide that coordination of care at all stages of life when we're trying to get information to and from different hospitals. Another reason why it's really important is so we can support evidence-based measurements and we can provide, pull data. We can do quality improvements with that. We have consistent reporting, and we're all talking the same language when it comes to data. From the patient's perspective, I will also say that this also helps the patient because when they have patient apps and they're trying to go into their information and we're using the same units of measure, it makes it easier for them to understand versus if one organization used a different unit of measure than another organization. And so, really being consistent with how we're tracking data and that standardization really help support that. But another kind of caveat to this, and we were talking about FHIR and HL7, are the ways we connect to each other. So if you can think about it as we're on a street and one street has to connect to another street to keep the traffic going. Can you imagine if one street stopped and all of a sudden a sidewalk was there and you're like, wait a minute, how do I keep this car going forward? Because now cars are not allowed into the sidewalk. So you have to think of, this connection as everybody's got to use a street and build it the same way, and it has to be the same size and the lanes have to be the same size to be able to accommodate the data that is coming across. So it has to be standardized just to allow data to flow back and forth seamlessly. And so organizations can put in standards to share data back and forth.
I love how you connect the technical side with real world impact. Hospice and palliative care rely heavily on CMS frameworks, CAPS, MIPS, and the HOPE assessment. How do these metrics influence your informatics strategy? Could you share a moment when data directly helped improve patient care or team performance?
Absolutely. So, yes, CMS is a prime driver of what we capture and how we capture data in an electronic health record. So a good example of this, again, using your primary care provider as an example, there's a lot of questions that they ask patients when they come in. They ask about how much do they weigh and do they smoke, or they take some lab values to see if you have high cholesterol or if you have diabetes. So some of these or a lot of these are required by CMS, and collecting data in a certain way allows CMS to evaluate whether an organization is improving care for a patient. So if I have high cholesterol and I am a doctor's office and I develop a certain program for the patient to help lower their cholesterol, the goal would be the next time I go to the doctors for that value to be lower. And so my cholesterol to be getting better. And the reason this is important for CMS is if we don't report on these measures or we don't improve upon some of these measures that we're signed up to capture and report on, we could then be penalized by getting a lower reimbursement rate. So CMS compliance is high on the priority list. So organizations that have a compliance quality reporting program that they have to report on, it's imperative that they collect the appropriate amount of data for the appropriate population, and then they report back on that. Another example would be for hospice, we have to make sure that we do a symptom impact visit or screening. So for hospice patients, what that really looks like is you might be at a pain level of 5, but how is that impacting your daily life? And if it impacts your daily life, maybe 5 is a tolerable amount for a patient. So it doesn't have any impact because they're used to it and they've had it and they're fine with it. But maybe for somebody else, a 5 is highly impactful and they just cannot function with that. So we do an impact visit, and then that data gets reported back up to CMS. But to follow along to make sure that we're providing good quality care, we have to then see the patient again within 2 days of that screening to make sure that we are being proactive in helping alleviate that impact for the patient. And so if we're not doing this and we're not seeing the patient like CMS requires us to do so, then in the year after we report on, so we report on 2026, in 2028, we'll see a negative reimbursement for our services. And so that can really impact an organization. In addition to that, some organizations have accountable care organizations, and they also track certain things. Maybe in one community, high cholesterol is dominant, or maybe, there's a high case of diabetes because there's low or no options for healthy food. And so they're trying to improve that sort of metric, and they're trying to improve diabetes and reduce those numbers. And so they want to see if a program is working for them. And so really tracking that data and seeing if those programs are beneficial really matters a lot for that accountable care organization or just single organization.
That really shows the power of meaningful data. Social determinants of health remind us that healthcare extends far beyond medical charts. How does your team integrate SDOH data to ensure care plans truly reflect the patient's environment, family, and quality of life needs?
So kind of pivoting off of what I just said in the last answer, we were talking about diabetes and having food deserts and communities not being able to have enough healthy options to impact those lab values. So that would be a social determinant of health, is the food desert, not having those options. Other things that really are important for organizations for social determinants of health would be transportation, being able to get to and from a doctor's appointment, or feeling safe at home and what their home life looks like. Or it could also be family dynamics, or living alone, or having caregiver support. So all of those things really need to be looked at when you're looking at the holistic care for a patient, because it's not just what their labs say or what is physically going on or what symptoms. Things are really driven by social determinants of health that can have a high impact on longevity and healthy lifestyle of a patient. If I am living somewhere where all I have around me is fast food places within walking distance because I don't have a vehicle, and then I might have an organic grocery store, but I am low income and I don't have a lot of money to spend on food, I'm going to go to the fast food place and order something that's relatively cheap versus going to a higher priced whole food grocery store, even though I know that it would be better for my health. So that's an example of how social determinants of health really impact patients. And so in hospice, it's a little bit different because we're not trying to be curative like we would in an ambulatory setting or a hospital setting. We're trying to provide comfort and care in that last stage of life. So what social determinants of health are really important to us in this environment is, do you have support at home? Do you live by yourself? Are you able to transport yourself throughout the house? Do you have, any safety concerns? What does your food look like? Do you have healthy food to eat? And so it's really helping them get what they need right now to live their best life in the last stage of their life. So depending on if you're in acute or post-acute space, could really depend on what type of SDOH questions you ask the patients.
That's interesting. Now, my next question is like this is especially valuable for our students and early career professionals listening today. Clinical informatics blends science, empathy, and problem solving. What transferable skills have you found most valuable in your journey, especially for students or professionals who may not come from a traditional tech background?
So I think if informatics had a superpower, it would be to be a translator, which is exactly what we are. We're really a liaison or a tech to non-tech translator. So we live typically, not always, but typically mostly in the IT department, information technology department. And so we hear a lot of techie lingo. But the rest of the organization are clinicians or operational staff members. And so they don't have necessarily a high-tech vocabulary. So a lot of the time, we're communicating or transcribing, if you will, what IT is saying to what the staff understand, the clinicians that are out in the field and the providers and our operations team, and kind of doing that transfer of information. So a good example of this would be when we think about EMRs or EHRs, whichever you say, that there's things that can be technically done versus things that can be configured in the system. And so what I mean by that is, let's say you get a new doctor and Dr. A wants to order A, B, and C medicine because that's usually what they order all the time for a certain condition. But you have Dr. B who's in the system and they like to order XYZ medications that are, maybe a capsule versus a tablet. So there could be different formularies or different type of medication. So that's something that would be configured. So we would build an order set for the new doctor and make sure that everything that he wants to do in the system works. But let's say now a doctor wants to trend a weight value for a patient, and the system just doesn't have trending capabilities. So that is where we have to communicate to the provider. Well, technically, within the system, we are not able to provide a trending value maybe in a graph or however they want to see that. But instead, we need to think outside of the box and maybe pull into some sort of BI dashboard so we can trend whatever it is that they would like to see. So it's kind of having those conversations and being able to communicate with them to say, okay, well, technically these things are not able to be done in the system versus what is configurable in the system. So I would say really the transferable skill is again, understanding the voice of the customer and what they're trying to do, and then take that technology language and put it into a real person's terminology that they understand and give them options. Because we don't want to say, no, we cannot do this. It's, well, it may not be able to be done here in this place, but here are some of your options and what we can do. So we're really problem solvers, also, which is another good transferable skill, right? Always looking for opportunities to make the practice, organization, office better. And so some people call them, problems or gaps that we're trying to look for to close. I like to use opportunities to present, right, and keep that in that positive mindset. So we really are translators, we're problem solvers, we're also troubleshooters. So we have to have that troubleshooting mind, and that doesn't just mean for an informaticist, that could be for technology or for anywhere where you have to kind of rule out things that if something is wrong, rule out things that are not, that's not what is the cause of that, and finding your root cause analysis and trying to find out why the admission time is so long, or why the transfer rate from one floor to another floor is so high, and what is causing that, and really evaluating that whole workflow to identify that. So that is something you can do in informatics, something you can do in IT, and just operations in general. So all over the organization, having that lens of looking from end to end. Another thing I will say for informatics is a lot of times in organizations, and, rightfully so, they are sort of focused on what they have to do. So they've got this siloed view because they're responsible for a really large amount of things that they have to do and accomplish, and strategic goals and things like that. And so when they're looking at it through their lens, this is what's important to them. But as an informaticist, we have to look at the big picture, and we have to not just look at their lens. We have to look at everybody's silos and kind of look at that top layer to understand how one process or one team or one office or hospital affects the other one. So every change that we make, we have to evaluate what our input is, what's coming upstream, and then whatever that change is that we're making, and what those impacts are downstream. So it's really a holistic view, just like our providers do with our patients, right? They want to see the holistic view of the patient. We want to see the holistic view of how our clinical systems are impacting the organization from start to finish, and for everybody in between.
Okay, that's really a great and helpful answer. So, all right, before we wrap up, let's do a quick rapid fire round to end on a fun note. So, are you ready?
Okay. Yes.
Okay. So, one word that captures your leadership style.
I would say transformative with grounded in servant leadership.
The health tech tool or app you can't live without, professionally or personally.
Definitely ChatGPT. I know it's not necessarily health related, but I am now addicted to it.
Everyone is addicted. Coffee, tea, or maybe a playlist. What keeps you energized during data heavy days?
Definitely a good playlist will keep me going. If I have to talk to a lot of people, I need lots of coffee.
A book, podcast, or mentor that changed how you think about innovation.
So I really love the book Extreme Ownership by Jocko Willink. It's not innovation related, but it's very leadership focused on how to focus on what matters right now. It's an amazing book. And an audiobook is even better because he reads it. So
If you could snap your fingers and automate one workflow tomorrow, which one would it be, and what would you do with the extra time?
Oh, well, it would be implementing our new EMR as our organization is going through a complete overhaul and putting in a new EMR in place. I would snap my fingers and have that done so I could focus on optimizing it for our organization.
Okay, sounds good. So, Rachel, thank you so much for sharing your time, your experiences, and your insights with us today.
Thank you so much. It was such a pleasure being here.
Yeah, your work is such a powerful reminder that informatics isn't just about systems, it's about people, dignity, and care.
Thank you. Thank you so much.
So, to everyone watching and listening, thank you for joining us for this episode of the HIAC One-on-One Podcast, We hope this conversation inspired you and gave you a deeper look into the human side of health informatics. We would love to hear your thoughts. What inspired you most from today's conversation? Share your reflections with us through HIAC channels and let's keep the discussion going. Until next time, I'm Agrani Sinha and we look forward to having you join us again soon.
Thank you.